to talk to you about laboratory centralization, our experience at the University of Washington Medical Center. I have no financial disclosures that are relevant to this presentation. I also like to make the disclosure that this is not a talk about the pending Department of Laboratory Medicine and Pathology Central Lab in Renton, although I'll make some allusions to it. Topic here is about our experiences, so I have no indication of any plans that related to that transition. Leave those to other in our department leadership to comment on. I'd also like to differentiate between consolidation and centralization. And I think this distinction that Dr. Cookson helped in our discussions about it, consolidation can be a bad word, can connote a reduction in staff and potential, decrease in resources, decreases in quality care, or FTEs, emphasizing a financial motivator. Here, I'm going to try to use, where possible, a centralization as a term, although consolidation is used in some of the papers that I'll mention. It tries to emphasize the positive aspects, the benefits, and the quality care. But I'd also like to take a moment to acknowledge that the centralization aspect can really have significant personal impacts on everyone involved in this process. At my first internship after college, freshman year, they were looking at moving the company and had a map of everywhere around the Twin Cities that people would commute, and that can have substantial personal implications for everyone involved. So I also take a moment to query the audience here about what do you think the goals of laboratory centralization, and for those of you on Zoom, I encourage you to chime in as well, and Dr. Schertz will try to read those off. So based on all experience, what you heard, everything we've talked about in the department, what do you think the primary goals for laboratory centralization are? Efficiency, is that what I heard? Adequate space. Closer to the airport for reference lab samples. Opportunity for growth. They say synergy. Yep, synergy. Interesting there that no one mentioned cost, and I'll come back to that here as well. I'll leave that slide blank for the moment and actually start off with a little bit of history. So the traditional patient-physician relationship is really centered around individual interactions and fee-for-service. After some of the major wars in the turns of the last century, there was really a spirit towards public health measures and efficient hospital systems. The early 20th century came a really acknowledgement of the value that pathology can have to the hospital systems, and this was advocated by our surgeon colleagues. Over the subsequent few decades, there's actually a lot of politics around it, and the advent of these, quote, lay labs. So as non-professionals, or at least non-pathologists, operating laboratories outside of the hospital to try to suck business. And then there was some politics around the American College of Pathology, trying to protect their turf and giving ethic violations if a pathologist were to work for one of those. That actually had some government legal intervention and that allowed that to occur, freeing up pathologists to be involved in laboratories outside of the hospital in a larger way. To me, has really laid the ground for laboratory centralization. We also have very related but slightly different concepts around standardization and harmonization. So standardization is about implementing the technical standards to implementing policy aspects, procedures to follow a published guideline. For example, our Clinical Laboratory Standards Institute. Harmonization is really making sure that what we're doing in the lab, the results are portable across the system. So making sure how we're reporting it in the information systems can be computed between those and interpreted by the provider in a similar fashion, or something like a WHO or CDC lipid standard. Some of the general objectives in standardization and harmonization initiatives to ensure transparency, accountability, make sure that patients have seamless access to the full test menu. The small hospital in the system should have access to the full benefit of care of the specialized academic hospital. Ensuring that we can quickly adapt to changes in the system, both technology drivers as well as clinical care changes, and that our testing menu reflects those changes in patient care. We want to ensure that we have our procurement, our infrastructure, our support mechanisms in the department. We have lots of instrumentation and purchasing that we have to do that is standardized throughout a system. And significantly, we want to ensure that we're able to be state-of-the-art, allow rapid adoption of new technologies, and really support innovation and development. However, there's a whole bunch of different drivers that can go into the standardization process. And so this author, blank on the first name again, Deidre Church, I believe, helps distinguish between the medical and scientific driven approaches and the managerial driven approaches. Each of these create their own set of drivers that when you're coming across standardization decisions. They estimate that roughly 30% of those decisions are really about that medical scientific approach, about the standardization, expert opinion, best practices, evidence-based medicine. Whereas a majority of the drivers in this are some external factors. Sometimes those are informatics, IT limitations that are outside of our control in the laboratory, as well as the business practices and market-driven needs. With that, balancing these medical, patient-centric and management business approaches, we have a risk for how we balance these, and the principles of laboratory medicine that I think many of us would relate to versus those of a Wall Street-driven industrial approach. So we want to focus on the stewardship, the quality, patient-centered care, and specific clinical outcome data. Compared to over-focus on the managerial approach can have a focus on throughput and efficiency, cost per test, test per FTE, the efficiency in their revenue. Things we deal with this when we have external consultants come into our system and have difficulty understanding the complexities of our system and how that's compared to other institutions. There's also a plateau here. Authors Mario Plebani advocate that bigger isn't always better. That at least for some tests, when you do gain some efficiencies up to around 1 million per year, but after that, that has a risk of decreasing when you start having your overhead and organizational needs start increasing. So there's a nonlinear approach. So throughout that entire low, medium, and high volume, we have to consider how that is relating to our patient care and the efficiency within the system. I'd like to give you an example of one published article about, to me, is a more cost-driven consolidation model. And there I'm using the term consolidation very specifically. This is an academic medical center on the East Coast. I'll avoid names, although you can find it in the reference. The primary goal, as included in their article, what was admittedly around addressing cost containment. They did have additional goals, however. That was to improve customer service, develop more cross-training in their staff, evolve their outreach business, all the while maintaining their academic mission. In their approach, there was an aggressive push towards patient care that saved technical salaries and captured more billing. They estimate that over a 4-year period of time, they saved $3.4 million. I've adjusted that to 2021 dollars. So it was in the late 90s when they did this. And they actually met and exceeded their academic goals as far as papers published per faculty and grants. However, the report card was mixed. So they did achieve some cost effectiveness and some of those cross-training and skill mix things where they pretty closely met a lot of their aims. Their customer service did generally improve, but they still had some limitations, particularly when centralized call staff didn't relate as well to what was going on in the ground and introducing themselves. Turnaround time, they admittedly did not meet many of their goals. And that a lot of is that the logistics, transport time to the offsite centralized laboratory. I'd like to contrast that now with what I think is a more professionalism or principles of laboratory medicine that I think we can relate to, driven approach. And this is the University of Maryland system. It's a nice article by Jim Cook. And I like to quote him here saying that from our perspective, the need for integration was intuitive, but the plan for integration was not. Their initial state here, this is kind of the mind-blowing number of laboratories. This is meant to show there is a steering committee and overall operational council, but all these silos with individual laboratories, some that had multiple laboratories within that, but you have administrative and pathologist leadership and lab personnel, and there's not good standardization or harmonization throughout the system. Interestingly enough, of course, this is the University of Maryland around the Chesapeake Bay, similar bodies of water and other logistical challenges that we face constricted around the Puget Sound. This may be a little bit hard to read, but their post-integration model really helped feed up, ultimately to a senior vice president and CMO through an associate vice president of lab integration. They really had this reporting structure with the motivation to allow all employees to have input and the responsibility for all the administrative, medical, and operational decisions. Now, it doesn't mean you can't have an ultimate decider. You have to have someone that helps bring those together to move forward. Not everyone can have their way. But how they approach this with a core laboratory kind of technical council, with subcommittees from each of what we would relate to as divisions: chemistry, microbiology, anatomic pathology. Those subcommittees reporting up to this laboratory council, up to that VP for lab integration. Now you have a separate arm reporting up to that VP of the individual laboratory directors, medical and administrative, at the different sites. Because as we know in our laboratory medicine practice, we have CLIA licenses. We have to make sure we're scribing each of our physical sites, even if we're part of that larger system. They very nicely talk about a lot of the obstacles to integration and centralization. I'd encourage you to read these in more detail. And directly quoting some of the higher level points that they make here. There is a lack of sense of urgency among some of the stakeholders, a lack of centralized lab ideology. When we're trying to harness these potential benefits from laboratory standardization, there's obviously going to be some factors that have to bend to gain those overall, I'll call it gains in the median. Sometimes we have to have changes that for one specific site, one particular specific interest may not be a general positive outcome. The hope is, of course, that that's balanced by the net positive. Mandated targets and goals here are also critical. An interesting aspect that may make some of those on the finance aspect a little touchy is actually an insistence on a detailed ROI was actually an impediment to making progress. So basically, throughout the integration process, can apply the faster, better, cheaper model in the sense of we need to achieve some intermediate aims, and that you have a chicken and the egg problem. The entire efforts to develop a test menu, to plan out the entire system is so large that you have to be pretty far down that path to get your really detailed ROI out at the end. And so you have to have those appropriate quality and drivers in the beginning to establish those aims and have faith that those will come to a fruition, monitoring that throughout the entire process. There's a lot of lack of structure for their system. I think we have some benefits here that they didn't have, including some more billing infrastructure on the reference lab, in addition to the hospital infrastructure around that. Centralized statistics and metrics, making sure we're using the same metrics across the system so we know what we're comparing and how we're going forward. Human resources departments. Within UW Medicine, we have different unions that are staff under the umbrella of. Some of the significant challenges there when we talk about standardization throughout a system. And then a lot of challenges of limited flexibility. We have our mindsets again on what we had, how we have the organizational structure in the hospital and technical director leadership, really staying focused on the aims here. And another important thing to acknowledge here, ability to have operational decision-making at each level. And so that you have supervisors, if they're lacking the decision to make some decisions or perform a task, you're going to bog down that overall change process. And then a significant thing that I can personally attest to is throughout all of this, this requires such organizational structure. There's an awful lot of meetings that come out of this, and particularly now with Zoom, that can make some things easier. It also makes things more back-to-back, but that can actually be an impediment to making progress because you're stuck in meetings all the time and too busy to meet. Okay. With that, wanted to transition to a little bit on the literature, specifically around microbiology centralization, the division near and dear to my heart. So one of the gold standard reviews in the field of clinical microbiology, the Clinical Microbiology Reviews, has a nice article about, and they use the term here, consolidation of clinical microbiology laboratories. A lot of the articles focuses on some of those technical aspects, our automation system in the lab. I'm going to focus on the more general here. Another key aspect, and I keep circling back to this, is the literature is relatively scant, despite the general push in a lot of systems to go towards centralization. And there's very scant peer-reviewed literature on specifically quantifying financial details of this. And it's particularly hard to quantify out that, and that becomes particularly challenging if cost is one of your motivators. This shows a generally accepted, I would say, model of a centralized microbiology laboratory, where you have some satellite labs that could be smaller sites, that could even be a main hospital site, where you have some component of rapid testing, stat gram stains, maybe some rapid molecular testing. And then that's feeding back to a centralized core laboratory, as well as in all your subspecialty laboratories within that. Core infectious disease serology, molecular microbiology, detailed mycology workup, BSL-3 facilities for acid-fast bacilli, including tuberculosis. And then all this other structure related to within the system, public health and informatics systems that accompany all of this. It's a key components here to me to look at when we're thinking of a model for a centralized microbiology laboratory, so, as well as applies to many other areas as well, is a need for realistic medical need for faster turnaround time. We always want faster turnaround time. Providers always want faster turnaround time. We can't always have faster. Something has to give in that system. To get fast for the tests that matter the most, we may have to be a little bit slower for the tests that aren't going to have as much immediate impact. There's all these pre-analytic logistics. There's also specimen that still may be analytic or pre-analytic, but really around that physical specimen. We also want to make sure we acknowledge provider and educational needs. One important characteristic to think about is identify and mitigate points of higher risk. So not trying to have folks be able to read this in detail. Here on the y-axis there is different specimen types. And on the top, on the X of the columns, are different pre-analytic and analytic steps. And so this, when you're thinking about centralization, urine culture, okay, high throughput, can establish, can have some pretty basic mechanisms that is more favorable to automation. It's also potentially replaceable if you have a logistics mishap and lose a specimen. In contrast to other things where you may have more sensitive samples, you have an immediate stat need for a stat gram stain on a CSF sample. You may have a labile specimen in anaerobic culture. You also have invasive biopsies, tissues, excisions, the patient that you can't go back to that patient without ending up with significant patient harm. So you have to have a very robust system and have redundancies throughout that to mitigate all of those risks if you're going to expect to move more than just your basic high throughput non-critical specimens. Okay, a couple of specific test types here, blood cultures. So always like most important thing we learned from undergrad and in microbiology fields at least, sepsis of course matters and timing is critical here. Quantifying time and the impact of that is actually a little bit more tricky than the surface may allude to. This is often potentially oversighted article from the early 2000s about interventions of severe sepsis. Among those aspects there's time to appropriate antimicrobial therapy. With the take-home message here, for this patient population, the specific interventions that they approached, that each hour delay in appropriate antimicrobial therapy resulted in 10% increase in mortality. Now, that patient population, the workflow in there doesn't necessarily apply to all of our patients or the current sepsis interventions. So keep that in the back of your mind. And then I'll mention throughout the country, there's 2 well-established models for centralized microlaboratories. When we have the option A, which is what we've implemented in the current state for Northwest. So you incubate bottles on site at the hospital. You perform a gram stain when that bottle goes positive. Some places may perform a rapid molecular diagnostic on that bottle on the site. We send that to main Montlake campus. And then that main centralized lab works up those cultures further. An alternative model here is you draw the blood, you send it to the centralized lab and deal with it, everything downstream there. So clearly many smart people around the country have put a lot of thought into this and we're currently split in the field. This can come down to where delays in this process that are going to have the biggest impact, positive or negative, on that result in interventions. That some of that time to initial gram stain and rapid diagnostic or time to susceptibility, where that transport time you're going to have the least risk to patients. So this is an interesting article that is actually focused on centralization, but the aspect here that I'd like to quote is a study of when our laboratory results change antimicrobial therapy for bloodstream infections. And so here we have gram stain, bottle goes positive, gram stain, you have an identification, and you have a sensitivity result. You may have additional intermediary steps in that as well. And then you have 2 main bins of interventions related to antimicrobials. You have de-escalation and escalation. And then you also can bin that into gram-negative pathogens, primarily gram-negative rods or Enterobacteriaceae, and are being our most common, and our gram-positives, particularly Staph aureus. Now, for some of this, they're probably underpowered, but the overall takeaway that I get from this paper is that de-escalation is by far the more common change that comes about from our laboratory results rather than escalation. These are our sickest patients, they're on broad spectrum empiric therapy. And so it's really about backing that off, reduce side effects and improve antimicrobial stewardship than it is about the chance of escalating. And we do have some significant resistance in a population, less so than many other areas of the country and the world. And so we do still have escalation. And there's, sorry, I'm getting the antivirus alert. So they have, particularly for the gram negatives, it's really about the identification and then even more significantly, the susceptibility results that matters for changing therapy. Now, what appears to be underpowered in the study, but had no significant differences between gram stain identification and susceptibility was that escalation model. So again, keep that in mind. We'll come back to a little about this when we talk about some of our Northwest data. Oh dear, this again. Okay, again, back to when are you introducing that delay in the bottle, that transport in the bottle? That unincubated or post-incubated bottle. So this paper used spike bottles with some of the most common pathogens and looked at that impact to time to detection from a delay in incubation. This happens to be the same blood culture model system that we adopted here last summer. And so they asked, like, when you introduce a 4-hour delay in incubation, you actually have less than that added time to detection, like 2 hours. 8-hour delay in incubation only had a 5-hour delay in time to detection. So it does, of course, increase, but it's not a strictly additive process. This is presumably due to growth of the organism within the bottle. Many organisms will grow well at room temperature and not require 37 degrees, although they grow faster at those conditions. With that, I'd like to have one more article from literature I'd like to mention, and that is around the impact of providers. Here, this is a survey of infectious disease providers and their perceptions around centralized microbiology laboratories. 86 of them thought it was very important to have an on-site lab for timely diagnostic reporting, communication. 75% felt on-site labs were very important for education and teaching. Turnaround time explanations. Again, everyone always wants it faster, always met only 35% of the time. Mostly or sometimes 63% of the time. Then experienced salt-type lab continuing, we have 74% had a negative perception of the off-site lab on their impact to patient care. 10% only thought they had a positive impact, primarily to adoption of new technologies. And 47% thought it adversely affected medical education. So these aspects of patient care, providers, and education are all things we have to think about, including things that I won't have time to talk about today. For us, plate rounds, the technologies, our interface with the providers, and the technologies that we can harness for those. I'd like to transition into some of our experience at Northwest. Also use the abbreviations here as far as University of Washington Medical Center, UWMC, and the Northwest campus, our more community hospital site, and W and Montlake, the main academic site, is ML. So some of the goals, at least those that I had in the back of my mind throughout a lot of the steps that I'll mention here, is standardize across the system. Expectations, same level of patient care. Our community hospital that's called UWMC should have the same advanced care that we have, the main academic site, compared to, let's say, a more isolated rural hospital that may not have access to that system. Procedures, training, there's a lot of benefits operationally from achieving these. Again, provide these advantages of both the technologies and laboratory expertise, both the technologists and faculty level. Want to ensure that we have realistic expectations for generalist technologists. They're fantastic technologists, but we can't expect them to have the complete set of subspecialty expertise that all of our folks that are just doing micro or just doing mass spec for drug testing. And here, again, turnaround times should be sustained or improved, at least when critical for patient care. Cost is not a primary driver. I have no data on cost of the outcome here. And if anything, I'd say my impression is probably it's a wash, some cost increase. One reason, adoption of rapid molecular diagnostics that improve patient care. I'd like to walk through a list of many of the changes that we have gone about at Northwest and that I think would help think about a framework for a potential future larger transition for our Renton lab, albeit on a much smaller scale. In 2009, Northwest Hospital becomes affiliated with UW Medicine. In 2014, Dr. Baird became their medical director. A lot of things that he instituted and sending on testing to Montlake and Harborview, we don't have time to go into here, but one of the main projects was transition of the laboratory information system. Huge project, standardizing with the rest of the department. Also laid the framework for potential microbiology transition. Took over the medical directorship of that lab in middle of 2018. Within a few months, we adopted our laboratory medicine residents for helping support the call that had previously been supported just by the medical director. To date, we have looked in the call database today, and we have over 800 log calls from our LMRs directly flagging Northwest. Then by the end of the year in 2018, we had a formal SBAR describing some of the different steps and potential benefits from further transition of microbiology. First, before we had a lot of the additional details teased out, we moved, for example, malaria blood smears, things that are very difficult to maintain technical expertise when you're not seeing them very often, as well as stool cultures. And that was because that's a less critical specimen than bloods, but we had the benefit of adoption of new technology. And then we transitioned our core culture workup through the mid of 2019 to the end of that year. Oh, sorry, still last point. January in 2020, we also transitioned our call center. We had our own call center staff. We integrated that with the department client support services. Throughout this, there was actually a hospital merger going on. That was previously Northwest Hospital, becoming in January 2020, University of Washington Medical Center Northwest campus. Northwest Hospital no longer exists. And so with that, we had standardization of our policies between the campus, JCAHO requirements requiring that to be the case. We moved on to transfusion testing here. Not even saying the pandemic, of course, it started in that period of time. With the transfusion testing, we started with our perinatal testing, our prenatal testing for ROGAM administration, which was done in-house, followed by a full transfusion service transition from BloodWorks Northwest to our main transfusion laboratory here at UWMC Montlake. We had the EPIC transition with D1. Now we had everyone involved clinically, operationally. This impacted substantially, particularly our informatics colleagues. We had actually a couple extra layers there at Northwest because the EHRs there were actually separate from the rest of the system. There's actually one of the drivers in that immediate change with D1 because sunsetting support for the system at Northwest. Continuing this integration vein here, in the fall, started also overseeing medical directorship for the anatomic pathology at Northwest. In December of last year, we'd integrated our couriers. Previously, we had couriers, some carrying clinical pathology specimens, others carrying pathology. Different courier routes, they'd be passing each other. Some of them, same driver carrying one specimen versus the other. That transition actually required a lot more effort than that sounds. It sounds an obvious move up front, but by doing that, we've been able to, again, the cost here, not the motivator, but by integrating those, we have more frequent runs throughout the day, improving the turnaround time across the board, particularly for the pathology specimens that had more limited service. Recognizing challenges not just in the staffing for our staff, but also for our pathologists. On our anatomic pathology side, we have open positions trying to recruit. It's hard to cover call for a site like Northwest that has many fewer frozen sections and doesn't have a histology laboratory. So we actually implemented telepathology systems and have call covered remotely, frozen sections at Montlake, and some rapid cytology at Harborview. And we're now beginning some steps as far as cross-training some of our staff, receiving staff on the anatomic and clinical pathology sides, where we can identify areas to improve efficiency and really help support each other. So when we're not getting AP specimens, that staff member can maybe help log in a big batch of COVID specimens from the drive-through, simultaneously looking at ways we could potentially help on the pathology side by integrating pickups surgical specimens from the ORs into phlebotomy rounds. Okay. So I'd like to mention here what the microbiology that's maintained at Northwest. I couldn't possibly talk about that, though, without mentioning the courier service. So we have roughly on days and evening shifts, roughly every hour service, 7 days a week. And then after hours coverage, at least every 2 hours or on demand. Now that is a large resource spend. That's a couple $100,000-ish to support that level of service. Doesn't make sense for an individual division. But if you're concurrently or slightly overlapping as we were for our microbiology and transfusion transitions, you now have a larger justification to improve that frequency of the couriers and then meet or exceed your turnaround time expectations. Getting back to the actual microbiology here, we do not set up any culture plates at Northwest or do any culture workups. We do have the blood culture instruments. We do stat gram stains on sterile body fluids, as well as the positive blood culture bottles. We have some rapid molecular tests, particularly for respiratory viruses and C. diff. And then a couple of other tests that are relatively easy to perform and could be open to centralization in the future as well. A couple of key tools in these transitions are administrative and project management. This is supported both at the departmental and at the hospital levels. Throughout particularly some of these later transitions, greater use of teams to help communicate with each other. Minimum of weekly meetings. In some of these cases, we tried to back off on that and slow things down and problems and miscommunications happen. But then reporting up to a higher level groups so you don't bog up your complete leadership team. Clear timelines. Some of these were internally and some of these were externally established. But some of those needed timeline buffers. We had D1, we had the pandemic, we needed some buffers in there. And then particularly when you have a large complex transition, and we did this partway through the micro transition, it was a test transition template. So just to briefly mention that here, again, primary driver, summary of medical appropriateness and the need. Then you have a large list of things that you have to, again, differentiate. What are the impacts for both the department or the Montlake or Harborview labs, as well as the Northwest lab? Financial, FTE, contracts, of course, our courier system, specimen stability, our procedure updates that we had to do. Of course, a thorough turnaround time impact. Providers, both messaging, changes in the EHR updates, ordering, educating the residents if they get questions. Getting your LIS test request in on time so it doesn't delay your transition. Updates to our online test guide. At this point, we also had 4 different EHRs that we had to double check. Order changes, synonyms, order sets, all of those had potential impacts throughout this. Other communication software, in this case, HC1, problem solving, add-on testing. Proficiency testing, updating our test menu, communication and critical results, and other client support services, and infection control aspects. We had a very clear stage transition in the micro. I won't go through all of these in detail. These are just the test codes. But in general, the goal was the less critical specimens first, optimize that system, continual process improvement before we're transporting those irreplaceable specimens. The one exception is we did actually move blood cultures in the middle of that process once we had confidence in the courier system and the timing of that. And that was because of the substantial benefits we anticipated to patient care because of that. Smaller test menu, but similar stage structure for our transfusion transition. A few key challenges as a generalist technologist. So this kind of necessitates a high degree of multitasking. It's a large test menu around multiple different benches. Some of people may feel more or less comfortable with one or the other. You're balancing these stat needs. You may only have 2 to 3, we've had, particularly during the staffing challenges in the middle of the pandemic, only 2 or 3 technologists to perform the testing on midnight shift. You have an MTP. That can take more than 1 tech full-time trying to get blood out the door. You have a code, you're trying to respond to the floor to the code. Suddenly have no technologist in the lab to perform all of the rest of your testing. So how do you balance, triage that, communicate those expectations with the ED, with the ICU, et cetera? Competency is a huge component. So this is one aspect that was challenging for us. We're performing stat gram stains, but when you don't see those cultures, you don't put that in context downstream, you don't see them very often. You're generalists, you're not just focusing on micro, hard to maintain that. So we've addressed that in multiple different ways. We've brought our micro techs from Northwest, have focused intense training, the Montlake Micro Lab. We've also implemented multiple reviews, so if there is an error, we have rapid ability to detect it. So before we even report the result, we have a second tech blindly review that same gram stain, make sure they agree upon that result. We also send this slide downstream to micro. They're reviewing it in the context of the culture workup and double check that everyone agrees on that. Of course, mentioned the couriers. I already mentioned the cost. The other aspect, that partly that what made this so complicated, there's at least 5 different bins of couriers, different budgets, different org charts around this. How do you integrate all of those? Specimen processing, most critical component, and I think probably if I were to say go back and think that I underestimated is wish could do better, was anticipating that up front with our initial micro move. We of course have the staffing and turnaround challenges. We'd address the FTE around technologist staff from Northwest to Montlake, but all of that transition, moving of specimens, extra batching, extra packaging of specimens, all of which that can slow down specimen processing. And the last component I'd like to touch on is some of the outcomes and metrics that we've done. A key aspect here is not just that stereotypical received to result timeframes, but really track those intermediate steps. When is it batched for the couriers at Northwest? When is it unbatched in Montlake Micro? Where is that? How is that flowing through specimen processing at both sites? And for some of these data here, I'd like to specifically acknowledge Nathan Bright, who've done a tense amount of work on the dashboards, along with Patrick Mathias, and then also Hamilton Sang for the transfusion aspect here too. So one example here, all those extra steps that we have available for secondary review at Northwest and that multitasking, able to show here that for those tests that we do perform on site, for example, stat turnaround time for stat CSF, roughly an hour, both Northwest and Montlake. Here, this looks a little higher than probably the true when we're excluding some of the complicated specimens here. Target is generally closer to 45 minutes, but using the same comparable metric here, pretty comparable across sites. I mentioned key aspects of benefits to the patients around blood culture. Here we had 2 significant technologies we were able to provide which weren't available in the previous state at Northwest. And that's rapid molecular diagnostics on the positive bottles to help establish a species identification for our most common pathogens and some limited molecular determinants, for example, MEC-A, help identify MRSA, as well as direct phenotypic susceptibility testing from that positive bottle. So here again, the model goes gram stain positive at Northwest, red at Northwest, bottle goes downstream to Montlake where we perform our Veregene, our particular method of rapid molecular method for that bottle. If you look at the median turnaround times here between Northwest and Montlake, as we'd expect, yes, the transport time does add a few hours to that additional time for our Northwest patients. That is admitted caveat to this. However, I'd also like to point out is the 10th and 90th percentile there. We have long tails in these, and one of those challenges there, midnight shift. So we have this rapid molecular platform, including at Montlake and Harborview, where it's currently performed at midnight shift. So we have some of the variability around the workflows and performing shift can be just as significant, in some cases more so, than the actual transport delays. We've also been able to adopt some direct phenotypic susceptibility testing, as I mentioned, This is taking alcohol from a positive bottle, plating it without all those subculture steps. You have the potential to get preliminary susceptibility information roughly 25 hours sooner than a standard susceptibility result. Okay. Emphasizing that, going back to that slide I showed from the literature, again, where particularly for our gram-negative pathogens are most of the changes made, de-escalation around antimicrobial based on the susceptibility result. And that I'd like to show you here. So here, this is a little bit tricky to have really comparable metrics. They've taken our top 10 pathogens that we'd reflexively do susceptibility on, taking patient, or at least accessions that only had a single isolate, so you reduce variables through digging out subcultures, multiple colony types, and then just looked at that received to final result. The final result is pretty close to reflecting that time the susceptibility result, final susceptibility result is reported. Looking over the last 5 years, including this year to date here, and we see our median turnaround times in the previous state pre-transition were longer for Northwest. This again, not even thinking about those rapid diagnostics weren't available. This is that final result. After transition, very comparable to Northwest to Montlake for our median turnaround time. In fact, pre and post, if you take all the results to date, basically over the time window I'm showing there, have a 10-hour improvement in turnaround time for our Northwest patients. While we have no significant difference between our Northwest and Montlake patients. A brief comment on just another test type here, enteric pathogen testing. This is again an area where we're harnessing these technologies that we didn't have implemented at Northwest, and that has the rapid PCR component. There's a ton of upstream analytics, specimens are logged in, neighborhood clinics, trying to see where is that patient from. But if we actually look at the median turnaround time, Montlake to Northwest, for all the patients received in the lab, any lab location, to initial PCR result is essentially within an hour between sites. That's biased by a lot of the clinic locations we have coming into Montlake. Sorry, cut that. So we can look at, right, last minute modification to that. If we look at those just in the ED, so patients in the ED specimen collected, sent to the lab, Northwest has to be sent downstream to Montlake. Montlake just has to transfer within the hospital. So we do see, as expected, roughly 4.5 hour additional delay for Northwest patients for that result. But again, the focus on here, how is that resulting in medical decision-making processes? And most of these pathogens do not have any microbial therapy indicated. May have a change in therapy. Dr. Fung has a nice paper that we did when we initially implemented that, showing some of those therapy changes. But most of those it's generally not a critical test compared to something like a blood culture. And then in that encounter, you have to present to the ED, be triaged, produce a stool, be sent to the lab, logged in, and resulted. And so not even counting those upstream components, we looked at receipt in the lab to result, median for Montlake is 5.6 hours. Time frame that may not be practical for many of our patients seen in the ED to make a change within the encounter requiring follow-up, whether or not there. And so less of a substantial impact than adding just a couple hours to that. A key component here, a median doesn't establish the full component. We have clinic hours, courier routes, when the test is performed. So things like bimodal distributions are critical to look at. Doing injustice to the transfusion, we've also tracked the turnaround times for that, seeing that we've met our stated expectations around ability to have testing to support release of red cell product. And in fact, we've met or exceeded the service that BloodWorks Northwest had provided us. I'd like to just recap a couple of, to me, what are the key takeaways. establish and publicize those goals, emphasizing the quality aspects, have those clear metrics on service expectations, have all those discussions up front, good communication around the expectations, changes throughout the process. Someone is going to miss that memo. Most critically, though, to me, is the logistic component to this. So kudos to Michael Tull and the entire logistics team, specimen processing division there. And to me, when I look at this and seeing those lessons we learned from Northwest and thinking how this could potentially impact in a Renton lab, we have a potential here to improve our patient care, including turnaround times despite transporting things off-site. And that is, if Renton lab allows us to staff more culture workup, more tests on more shifts, more flexibility for FTE hiring, then that could offset some of those transportation delays. With that, there's a whole ton of folks here that are involved in all of these projects. Some of them I didn't have time to mention, including some of the pathology, integration of the residents into our service. And I'd just like to leave that there for a moment. Julie Del Moro, the administrative director for the Northwest Clinical Lab, is going to key partner throughout all of this process, as well as more recently Alan Lee on the pathology and Brett Norquist, administrative leadership for the Montlake and Harborview aspects, emphasizing the role of that dyad between medical directorship and administrative directorship, in each harnessing our strengths and value to the system. That I encourage you to get your CME and provide any evaluations you have, and happy to take some questions.
I was wondering if you talked about some of the literature that providers had perceived that the quality or turnaround time or different aspects that actually decrease with centralization of the microlab. And I was wondering if you surveyed providers at Northwest and how they have perceived the centralization.
So the question is literature about the perception among infectious disease providers around delays in offsite laboratories, and I surveyed infectious disease providers at Northwest. Haven't formally surveyed them. There's only a handful of them. Meet closely on weekly and microbial stewardship meetings that involve all of the hospital sites, and we've communicated closely throughout this. Haven't through each of those stages clearly met with them and established the changes that we're undertaking. Throughout that, I would say I think some of those negative opinions, when you look at a large survey, a lot of those relate to a lot of the centralization projects actually limit the service hours. So some of the papers that show poor turnaround times and poor opinions about how things went, it's more limiting, more like day shift, not having full, off shift workup. And so when evaluating literature, the perceptions, the emotional impact of all of this for our patients and ourselves, giving the goal here, and realistically, when are we going to staff this? How are we? Is that going to limit service or expand those? And to me, the goal is to expand those, not to limit them, like some of the consolidation papers show. From the Zoom.
Jonathan Paul of Matinee says thank you. I have a question on one of the graphs you showed at the end. Then you showed how the quality improved from how the turnaround time stayed the same. But then in 2022, it looked like there was a substantial improvement across both Northwest and UW. Do you know what the reason for that is?
I think that's probably sampling. The 2020 so far, there are roughly 60-ish and in there compared to like 300 plus in the others. Don't have other clear explanation for that. Although welcome insights from my microbes, others on that aspect. Certainly there's so we got an issue of what pathogens we're identifying and when. We haven't made any significant. I'd say the one last summer though was the change in the blood culture instrument. So that would have impacted partially for the 2021 numbers, roughly a third of the year, and quarter compared to all now. So that's actually a potential difference there in the blood cultures, and actually some of the literature on the virtual system we have does show some faster time to detection than some of the other models.
That was really nice talk, Andrew. You pointed out that you made the suggestion actually that there'd be training facilities at the central lab. And so, you know, obviously for our student trainees in the MLS program, our residents and our fellows, having some training space, I think, is probably going to be a really important attribute of that central lab, so that everyone gets the opportunity to be exposed to the technology that's available only in a centralized location. I wonder, you know, you also showed us that there was some improvements in the care that at the Northwest Hospital because there was new technology incorporated. In particular, that's the BioFire for stools. So I wonder if you'd maybe expand a little bit on what you think the training facility or curriculum might look like at a central lab. And I guess I would ask you if you think that there would be technological workarounds that would allow us to have people at the central lab that could train people that would never have to leave, let's say, Montlake or Northwest.
So a question about training space at the central lab location for both technologists, residents, new staff, and have balancing that with the hospital-based spaces. So they're a very important question, particularly if we're asking folks to migrate between sites. And we're definitely for Dr. Mathias and our residency program directors for any specific, as well as our technologist training program for any plans that they would have in place. Some of the off-the-cuff discussions we had in Train the Lab, I happened to be with Dr. Pagano during that, and we talked about with Dr. Mathias having some training space, have resident space there, and resident rotations may be a mix. For example, you want them to have a connection to the hospital, you want them to have understanding of that laboratory space. And so for a more hands-on specialty, we're rotating at benches, maybe you spend a little bit more time at the bench, including at micro in a central lab, versus transfusion, you're more hospital-based, so you're balancing that there. For training aspects, there are telepathology, certain for anatomic pathology and heme path, where we don't need the 100x resolution that we need in micro. More tools available for there, as shown by implementing the telepathology at Northwest. That can be harnessed across sites fairly easily and is in place at Harborview and Montlake already. A little bit more challenging for oil resolution, for gram stains, et cetera, for microbiology. So there are some systems there that can help support that. Probably not in a throughput that we would need for the, the 5 minutes or whatever we're allowing someone to review and turn around a whole bunch of stat gram stains, but potentially there for selected applications for training purposes for whether that's stills or some limited fields of ability to scan around at high resolution. One last one there, hoping to also including collaborate with HemePath, who has some additional higher magnification needs, just like we do for any potential implementation of a higher magnification telepathology system. Thank you much for your time.